Center for Addictions. He's going to give us a lecture on what they do, and he's going to kind of open it up where you can ask some questions to him and stuff. And there's a lot of things that apply to us and our job that relate to the patients that they get.
Oh, my reading glasses just broke.
Oh no!
So buy you some tape.
What strength do you wear?
1.5. You got them?
Pretty close, Doc. 1.75.
That'd be a whole lot better than nothing that I've got. That's $1 million for us. Where's my little clicker? Okay. Welcome, captive audience. I know you just went through a very intense lecture. I sat in on quite a lot of it.
Sorry.
Well, I remember those days in medical school with all those numbers about lung function. I've received the privilege of talking with you. The topic is addiction, as seen from the standpoint of we at the Center for Addictions who treat the patients who will show up for treatment.
Yes.
And I would like you to have our perspective. You're out on the streets, you're the people that see the consequences of it untreated. I certainly want to talk about the overdose thing when opiates are the issue. But the main thing is that you'll know there more than just that there is a center. You know, everybody on Cox's staff knows there's a center, and almost nobody knows anything else. So we want it very loud and very clear how to access our services. If nothing else happens, that needs to. I'm actually not going to work from the PowerPoint at first, but from the handout. I've slept through many PowerPoints myself. To me, the PowerPoint is mostly enrichment. I guess I have till noon. Is that
yes,
correct?
Sir, that's
okay,
correct.
Well, what I'd like is to speak a few minutes and then take questions from the handout, and then interested people can see the material on the slides as we go. It's very interesting stuff, but it's enrichment. It's not the main topic. So let's start by not mimicking the headliners, but by talking about good old-fashioned alcohol. An awful lot of why we have cred as clinicians is because we're not just literate, we're numerate. The average person, what's 10 times 50? You do that before I can ask the question. The average person can't do that at all. They have math anxiety. You know, they think math is simple arithmetic. We're not even talking about algebra or calculus here. So realize, just with your scientific education and ability to crunch numbers, you've got a running start. Well, how do you use that clinically? All right. One standard drink, one beer, one glass of wine, or one shot of distilled liquor, which is not an ounce, but it's actually close to an ounce and a half, contains 14 grams of ethanol. It's not the amount that you swallow, it's the liquid. That's what it delivers by that's how much ethanol it delivers. And it raises the blood alcohol level 20 to 25 milligrams per deciliter. The unit is point such and such and such percent, which is really quite confusing, and I'm not going to change that because it's been done since the year one. But 0.001% or 0.01% is 1 milligram per deciliter, so fear not. It's the same units you use all the time. Simple way to remember is one drink raises blood alcohol 20. So to get legally drunk, you need 4 drinks. Thank you. Being able to do that in your head now. You need 4 drinks instantaneously intake. Of course, that's not normal drinking behavior, but I'll tell you why this is important. You get old Jake that's got a blood alcohol of 200 on your gurney. Yeah, well, I might have had a couple of beers flipping burgers 3 or 4 hours ago. Well, you should be able to do in your head, if you have the number that it's 200, maybe that'll be in the ER. I don't know if you can do breath alcohols in the field, but just knowing whether you're at the bedside in the ER or whether you're in the field, 200 means that he's had at least 10 drinks. And since that isn't normal drinking behavior, that you chug them all, he's probably had more like 15 drinks. Now, this isn't a trivial thing to know. It's not. It's important. Because we're numerate. We're reading this like we'd read a sodium, like we'd read a calcium, like we'd read a glucose. We need to know numbers, and very few people are even trained in something this simple. Fellow doctors, emergency room doctors, you usually don't know these numbers. I had to learn them. I really wasn't aware of them until I got into addiction practice. So what's the good news? Well, a normal liver will remove almost exactly 20 milligrams per deciliter from the blood per hour. So that's the wisdom. If you have one drink an hour, you won't ever get drunk. But the flip side of that is also important. Let's say you start at 200. Well, an hour later, you're at 180. An hour later, you're at 160. If you had a blood alcohol of 240 in 20 hours, or in 12 hours, sorry, you'd be zero. So you couldn't even prove the person had been drinking with just a blood alcohol concentration as little as 12 hours later with normal liver function. So here comes the fun part. And we do this at the center all the time, and I'd be very surprised if you'd ever heard anything like this, because I certainly never had. There's a metabolite of alcohol, ethyl sulfate, ethyl glucuronide. They're both made by the liver. Once it forms, it stays in the body and is not excreted in the urine for as much as 80 hours. So we can detect ethanol intake as much as 3 days after the person would be completely at zero. Not just would be no longer legally drunk, but would be at zero. So the people that drank on Friday, we're going to get positives on Monday. Now this sounds a little hokey, but it's very real world when we're trying to deal with alcoholics. Alcoholics lie a lot. And they may well know that nobody can prove they were drinking days later with a blood alcohol or a breath alcohol, and we can't, but we can with ethyl glucuronide, ethyl sulfate. Now again, I don't want to get too nerdy here, but it is a metabolite and it's detectable on drug screens done in settings like ours. We do this on every patient, every drug screen, even if the person is not there for alcohol. Because it's not okay for a heroin addict to be an alcoholic that they don't think to mention that they're an alcoholic. All right. A little about liver cirrhosis. It takes a ridiculous amount of alcohol to kill the liver. Thousands of kilograms, like a hot tub full. And that's not of the liquid you drink it in, that's the ethanol. You got to kill 90% of the liver in order to die of liver failure. Dying of cirrhosis, you swell, you stink, you itch, you turn yellow. I mean, it's not a quick or dignified death. Most people, as you know, die of cirrhosis because of a bleed and infection. But at end stage, you're in vital organ failure. That is the equivalent of a half a gallon of distilled alcohol per day for 20 years. For underachievers, it would be 1 quart a day for 40 years. But again, do the math. You start drinking seriously when you're 15, 16, 17, you die of cirrhosis when you're 38. My personal record of a death for cirrhosis was the age of 39. My boss, Dr. Carlson, recently lost a person he'd been treating many years from cirrhosis at the age of 53. So your liver fails, you're gone. It's not a treatable condition because of complications late in the course of the failure. So did we bash alcohol enough yet? Because I'd like any questions as I go along about it. But alcohol is very much with us. It's a legal drug. Alcohol is at least as common as an addiction as pretty well all the other addicting drugs put together. So nobody should ignore it just because it's been around forever and because it's legal. But if you have a take-home lesson, one drink raises you 20, and the liver removes that 20 per hour. So you can get a blood alcohol or a breath alcohol and tell how much intake the person had to have had. Now that's powerful knowledge. Right. Any other questions? Okay. Drug screening. This is part and parcel of what we do almost literally every day at the center, and it's done in any addiction treatment program because, once again, we can't rely on our patients to give a reliable history of whether they're using. Drug screening of water-soluble drugs, which are basically going to be all the opiates, meth and cocaine. If you have normal kidney function, you'll go from however intoxicated you were to completely clean in roughly 2 days, maybe 3 days. That's real straightforward chemistry. I've got a lot more material on drug screening I'd like to show you if time and energy permit, because it's real interesting science. And for the record, every positive drug screen that is put out by a certified lab is tripled. It's screened and then it's verified by 2 independent technologies, GC and MS. I promise not to go into detail about what those are either, but they're highly sophisticated analytical chemical techniques that just simply don't have a significant false positive rate once they are completely all in agreement. So, I took whatever, and that made my drug screen falsely positive. No. It's about like having a falsely incorrect DNA report. You know, the chances are 1 in hundreds of thousands like. But I think that knowledge is important too, because the tests are highly reliable, the labs are highly quality controlled, and all these things are cross-checked before they're ever reported. If you do have a positive drug screen, there is a physician who specializes in the field called a medical review officer. This is in an occupational setting. I'm getting a little off to the sides here, but I wanted you to know this because I've got work comp experience and I'm trained as an MRO, practice as an MRO, who will call the patient or call the person that gave the drug screen and say, do you have a legal source for whatever was found in the urine? Now, for illegal drugs, that's not relevant. But for instance, for opiates, it is. If the person does, the MRO will note that they're ruling the test negative because the person's got a legitimate source of their drugs. This isn't a small point because some of the people are still trying to work. And if a person has an addiction problem, they will sometimes needlessly fear that some of the medicines that we use to treat their addiction will be found in the drug screen. Well, the MRO is the safeguard there. Everybody who has a positive drug screen, it isn't reported directly to the employer. It's vetted, if you wish to use the term, by a medical review officer. Many people don't even know there are such doctors, but they're actually fairly significant in the employment scene, the work comp scene. And there is a cutoff done on drug screens, so technically a person may have a certain amount of a drug found in the urine, but it'll be reported as negative because it's below the cutoff. So here's the gotcha. THC, the active substance in marijuana, is stored in fat, there to equilibrate back out into the circulating blood and be excreted by the kidney. So if a person is smoking marijuana or eating the funny brownies daily, consistently, they can be positive for marijuana for up to 3 to 4 weeks. And that's kind of an interesting gotcha also. Again, we have people that check into treatment for heroin, meth, or whatever, and they're positive for marijuana, and they kind of get all huffy because we don't think that's okay. And it'll be detected for a long time, so they can't just abstain from using another drug a few days and test negative. Again, interesting technology, but relevant. Okay. So what about the doctors doing something about addiction? Well, for alcohol, meth, coke, marijuana, as far as that goes, there's not a medicine that helps a person stay clean or sober that we know works and that we give evidence-based and that we have expectation will get us good results. There are medicines we can give, they just don't work adequately for most people. I'll put a little asterisk beside naltrexone, closely related to naloxone, which is given as the Vivitrol shot. That's given for alcoholism. My experience is it just really doesn't work very well. The shot costs $1,800 per dose, and it's good for roughly 3 weeks. So if I'm going to give a patient naltrexone, I never give a 3-week injectable before I've given the oral drug to make sure that the patient will tolerate it. I think that's just good clinical sense. But the main thing that the shot does is ensure compliance. A person cannot remove the shot, but they can not come in for the next one in 3 weeks. It's said that naltrexone is anti-craving. Interestingly enough, it works on the opiate receptor, but it has to do with other brain centers that prevent craving for alcohol too. And so it achieves small fame there, but it isn't like we're all on top of alcoholism just because we can give a butt full of Vivitrol every 3 weeks. It's certainly not that simple. So here's much better news. For the opiates, which are all derivatives of morphine or related to morphine, hydromorphone, oxymorphone, hydrocodone, oxycodone, codeine, of course. And then the ones that are chemically unrelated but work in the same parts of the brain are fentanyl and methadone. The oldie but goodie Demerol, which the older people will remember, which I think is no longer available. And then Tramadol are kind of different players because Tramadol is so much less of an issue and Demerol is not really available. When a person gets addicted to the opiates, the classic is the person injecting heroin. But there are plenty of people that are addicts to pain pills, plenty that are. And then there are people that will snort heroin, they're not all injecting. The drug buprenorphine, given in the context of a treatment program that the patient works diligently, satisfies cravings and prevents withdrawal, and gives a much, much greater likelihood that the person in treatment will stay sober, like five-fold greater, like 500% more likelihood that the person will stay sober if they use this. Now, there's some wisdom. Well, you're just addicted to a drug the doctor's ordered for you. Well, there's kind of a big asterisk beside that statement, too. First of all, the medication's ridiculously safe. You almost cannot die of a buprenorphine overdose if you want to. We have never had an overdose death at the center. That's all three of us for, I don't know how many hundreds of patient years all put together. Minimal interaction with other drugs, very low risk of liver or kidney toxicity, and the most important single thing that I've got all highlighted here is buprenorphine doesn't cause tolerance. We get a person on a couple a day, 3 a day, whatever the effective dose is. That's what they'll be on in 3 years, 5 years. It doesn't cause tolerance. All other opiates have the property. You need more and more to achieve the same effect. That's why the junkies all have to escalate their doses, but you'd anticipate this is an opiate, even though it's strong, distantly related to morphine, it'd have the same issue. It does not. It does not cause tolerance. You get a stable dose, it works, and it continues to work, and it continues to be safe. It is unique among clinically used opiates in that way. The science that we can understand about that is buprenorphine is an agonist-antagonist. It's not a pure agonist to the opiate receptor. So it partly blocks as it stimulates. And one of the other interesting things about it is if a person takes other opiates while they're on bupe, it's like they had a small amount of naloxone, a small amount of Narcan. All of my junkies have to try this. Okay, they'll take their Suboxone, but then they'll shoot up a little first week or two. We'll find it in the urine. Well, yeah, that was sure a waste of money. Could get high. I mean, these people all have to try it. They all do, but they demonstrate the science rather nicely because they can't get high off their other opiates when they're on bupe. Am I going to declare it a wonder drug? It saves lives every day. I think that's enough to say it's a valuable treatment. Now, it isn't cheap. Buprenorphine in all forms is expensive. It is not yet another pill. It has to be given under the tongue. Certain other meds you're familiar with do, or oral meds anyway. Migraine remedies, Zofran, Nitro, because if you swallow it, first pass liver metabolism takes it out, and it isn't effective. There is a skin patch, which I'll try to get into when I'm talking about chronic pain. Buprenorphine is made as an injectable, but even though I've begged, pleaded, and threatened the ER department, they won't stock it. But it is available. It's something that we can actually give people as an injectable. When I had my own private practice clinic, I didn't want opiates in my medicine cabinet, and I used Buprenex in my private practice because nobody'd steal it. So it's been available a long time. Even seasoned clinicians often don't even know that's available, so that's worth knowing, I think. Right. I do have quite a bit more detail, but do I have any questions so far? Sir?
You're saying that Suboxone injectable is available?
Well, buprenorphine is. So Suboxone is made for oral use. Suboxone is actually a double drug. If you look carefully at the designation, it'll say buprenorphine, so many milligrams, and it'll say naloxone, so many milligrams. Well, the reason that's done, there are a few people with the wrong nervous system who can abuse buprenorphine. It's very rare. But the strip can be dissolved and injected. So if a person tries to do that, they're just giving themselves Narcan. That didn't accomplish a lot. But that's why buprenorphine is, well, Suboxone is preferred because it's abuse deterrent, but it's not the only preparation available. And then just pure buprenorphine made up like morphine would be. I think 1 mg is I think it is, per milliliter, because it's very milligram potent, is the Buprenex injection.
So would you propose a course of action, a clinical course of action for a person with a narcotics overdose who we suspect of abuse? Would you propose that we use emergency department injectable buprenorphine prior to their subsequent discharge?
Well, the reason the bupe needs to be a player is because the patient is going to need something or they'll just go out and use again. You know, I mean, everybody has seen that. My gracious, you know, probably 8, 10 reversals of overdose on the same patient once a month. But are we going to start Bupe as a treatment for the addiction in the ER setting? There's no clinical or even medical legal reason not to. But first, the patient's usually not willing because they haven't admitted they're an addict. Hello, I've nearly died of heroin overdoses several times, but I'm not an addict. And I've had people look me right in the eye and tell me that. Everybody up and down my block uses horse. We're not addicts. They're not. What do you mean? I'm not an addict. So you've got the denial there. But of course, most of my fellow doctors aren't comfortable giving Bupe. They think we ought to do that in the setting of the center, which is okay. And of course, starting it when a person doesn't finish it or doesn't work the program doesn't accomplish much. But could you give it in that setting, and would it have benefit? Sure, it would.
What's the duration of effect?
If you get a steady state, which requires several doses over a few days, it's something on the order of 22 to 27 hour half-life. So it's very non-roller coaster. If you take 3 doses a day, you never hit 0 between doses. In steady state, you'll always have some level of drug. That's one of its many advantages too, is it's so long acting. So although you do withdraw, if you stop the med, the withdrawal is much, much gentler and much slower, which is, kind of worthwhile to know on the street too. Probably what's a little more sophisticated idea, when a person comes in who's on Bupe and they've got pain, that is that whatever amount they're taking isn't treating adequately, they can be supplemented with more Bupe. I mean, that's perfectly okay and will work clinically. What's usually done is the patient's just given these great big doses of opiates that will overcome the partial block that Bupe produces. Burn, break your femur, have an MI, whatever. The ER docs are sophisticated enough that they'll just push through the blockade. They might need 50 mgs instead of 10. But you can eventually get pain relief even on a buprenorphinized patient. It's not an easy thing, but people that are experienced in ER can do it. And anesthesiologists are surprisingly comfortable with this kind of stuff because they've just seen a lot of patients with it. It really is a good molecule, but it does take a little worldly wisdom and street smarts to know how to use it optimally. And then you just have to be comfortable with the fact that it's a very safe drug. It's really very hard to hurt a patient with Bupe. It really is. As I say, we've never had an overdose death at the center with it. Never. We've had plenty of our patients die of overdoses, but that's when they relapsed and went back to their heroin or whatever. So
To push through that, would you recommend, using fentanyl?
fentanyl certainly is an opiate
Yeah, but-
that will overcome Bupe.
Okay.
Any will.
Okay, I just didn't know if there's a
It will, but
differentiation
conversely, now
with that.
fentanyl is reversible, an overdose of
Yeah.
fentanyl is reversible by Bupe.
Yeah.
I'm sure you've probably seen that clinically.
Yeah.
So is methadone. A person can take a handful of methadone and they can at least be brought down to where they're breathing again with naloxone, with Narcan.
Fantastic.
Now, about Narcan, I'm constantly amazed and even dismayed by people that are experienced opiate addicts who have come to our center for treatment. They're there because they're trying to turn their lives around, who've never heard of Narcan. I mean, these are people that, they might even know that there's an antidote out there that the ambulances give their friends that OD'd, and that's why they're not dead, but they don't even know the name of it. And you'd think the first thing that a junkie would get a hold of would be some Narcan, so if they felt themselves going down, they could reverse themselves and not die, but they just don't know about it. The pushers ought to know about it, the drug dealers, and provide it for free, because a dead junkie's not a customer anymore. But this is just not street wisdom, so be aware. It's bread and butter to us. We all know about it inside out, backwards and forwards, but there's a surprising amount of ignorance on the part of the people whose lives it could save. Because it's become a headliner, Narcan in some states is available without prescription. It's never been a controlled substance. You could always get it on a doctor's order, and I've ordered it for people a number of times. But that's always going to be the injectable vial. Well, they make a nasal Narcan that people can purchase in certain jurisdictions without even having a prescription. Costs about $75, which is a rip-off because there's, 20 cents worth of drug in it? I don't know, whatever.
Plastic.
The EpiPen-like injection that's preloaded is $3,000. Now that is a rip-off, even more so. But it's the free market. Nobody regulates these things. You all have Narcan. You all know how to use it. I hardly need to tell paramedics about this sort of thing, but just realize even pretty well-informed medical colleagues may know not that much about it, and the junkies who need to know it the most often don't. They are simply unaware of it. I gave this talk, or a very similar talk that I gave the PowerPoints to a group of practicing psychologists at the Burrell Center about a year ago. You know, and with low impact, I hope, I said, now does everybody here know about Narcan? Because I've been talking about opiate addiction for an hour. What? All the pens came out, everybody in the room started making notes. These are people with PhDs in psychology that treat addiction, and they never heard of Narcan. So just understand, get the word out, life-saving antidote. You cannot hurt a patient with Narcan. You suspect you got a person down with an opiate overdose, you give Narcan, you can't hurt a person with it. What's the dose? Enough. You may need 2 or 3 vials. I personally never needed to give more than 2. But I've heard stories of 3, 4, 5 vials. You know, don't be afraid of the drug. You're not going to hurt anyone with Narcan. You're bagging, keeping the air moving, this sort of thing. Usually it's very dramatically and very quickly effective, as you've all seen. But it doesn't last forever. So if you've got a long-acting opiate like methadone, you can have the effect go away, 6 hours roughly, I think is what the publications say, and have the person go down again because they've still got a high level of long-acting opiate in their system. All right. Now, once again, you all know this, but many medical colleagues don't. I've had many well-trained fellow primary care doctors have patients present, hey, I'm out of my Percocet in withdrawal. What are you going to do about it, doc? And I say, well, first of all, you don't own their drug habit. You don't have to do anything about it, legally or medically. If the patient seems unstable, they may need to be admitted. So there, you're not going to treat them in the office, are you? But opiate withdrawal doesn't kill people. Alcohol withdrawal can kill you. Benzo withdrawal can kill you. Opiate withdrawal doesn't kill you. That may seem trivial too, but it's worth knowing because the people are so dramatic and they're so demanding. Here's a real pearl. I've taught many fellow doctors this. Doc runs up to the telephone to talk to me on duty in the ER. I've got an opiate withdrawal. I say, okay. What do you mean? Aren't you going to go to battle stations and get dramatic with me? And I say, no, not really. What are the patient's vital signs? Oh, well, they're better than mine. You know, the doctors always know this. And I'm caricaturing this a little bit here. So I say, does the patient have goosebumps? And the doctor never knows that. They got to run back to the bedside, run back and say, no, they don't have goosebumps. And I say, you got a stable patient, doc. If you're really an autonomic storm from opiate withdrawal, which may be a reason to admit a person, you'll have piloerection, nausea, vomiting, diarrhea, tearing eyes, yawning. Those can all be faked. All of those can be faked. They're very subjective. But goosebumps can't be faked. So if a person's got piloerection and their vital signs don't look good, they may need to be admitted, but that's uncommon. Can you give the withdrawing patient buprenorphine? Will it work? Many of the more knowledgeable junkies will buy Suboxone or Subutex on the street and have a little supply, so if their pusher gets shot, thrown in jail, whatever, and they don't have a supply of their usual opiate, they'll take the buprenorphine so they don't go into withdrawal. And when we begin a patient on buprenorphine, we actually, at the center, we actually want the patient in mild withdrawal. So we can show them with their first dose of the medication that it'll treat the withdrawal. We actually instruct the patient to have their last dose roughly a day before and to come in hurting a little bit. And we can show the person in 20 minutes they're going to absorb it from under their tongue and they're going to be comfortable. Again, this may seem hokey, but we're talking about people that live from shot to shot here. You know, and if we can't show them we can keep them comfortable with an effective medication, they're probably not going to be back. So it can be given for, and it will work for, and safe for opiate withdrawal. Hopefully that answers an unasked question too.
It's getting there. So if, you know, just to carry that question on, just to the next step. When I reviewed our use of Narcan over the past 3 years, in 2015 during one time period, we used roughly 20 doses. The next year, 2016, we used 20 doses roughly. Okay. And then this year, so far today, we've used around 225 doses.
Okay.
So at this point, we are Narcaning people and then cutting them loose. to a certain extent, not all of them, obviously. And some of them we're just not giving Narcan, we're just bringing them in. But for the reversed overdose, would a dose of intramuscular buprenorphine blunt their subsequent doses and increase the likelihood that they would seek additional treatment?
Well, I can't see how it could possibly hurt anything. If it's the person's first dose and it shows them that they can be reasonably comfortable with the drug they can get from a doctor, yeah, win-win. I really don't see how there's a downside to that at all. Now, of course, the person's got to follow through. One dose is not a recovery. But you could even give the med sublingually. You know, it's immensely cheaper like that, and you don't have to give an injection. And I mean, it's absorbed in like 6 minutes.
Is there a difference in duration between the sublingual and the intramuscular?
Not a clinically significant, no. But you know, once you push the plunger, the IM is in, and it's going to be in the patient system 36, 40 hours roughly from even one dose.
And it decreases the effect of any subsequent
Correct.
doses.
Because it's like very similar to a small dose of Narcan.
It's a 48-hour Narcan,
Yep.
and it's $10 a dose.
I don't honestly know what the injectable is, but the strips are much cheaper than that. Well, they're not lots and lots cheaper. Suboxone's about $1 a milligram. $8 a dose, $8 a strip. But either way, it'd be very cheap and a very safe intervention. And then you want me on the record advising you that, I'll gladly do that, or have Dr. Carlson do that. That's being done in some of the bigger cities with overloaded addiction centers and that sort of thing, proactively, yes it is.
Okay.
Yep. Ma'am?
May sound like a dumb question.
There's no such thing as a dumb question. One.
Yeah.
Oh, yes, there is.
When we have a recovery now, they're proud. You know, I've been 9 months, I've been 3 years,
Okay.
and yet they have a medical problem or an injury and they need pain relief.
Okay.
Are we being detrimental to them, giving them pain relief?
Well, hopefully you'd have a protocol about that because it's becoming so common. You know, we have a lot of patients that are opiate addicts, and so do other centers in the city. Again, you can't hurt the patient that's on a full, steady state level of Suboxone by giving another opiate. It's just that the ordinary doses won't work because the patient's been partly antagonized. But opiates will still work. You know, broken femur, horrible burn, MI, I mean, you don't have a lot of choice there. I would assume you're in radio contact with the ER, so you're not going to be given a lot of doses for a long time until the patient hits the ER. And I'd also assume the ER doc would be comfortable having you give, you know, just kind of as needed opiate, knowing the patient is on view. I'd be a little surprised if they didn't say that. I would if I were on duty there. But the answer to the question asked is, knowing that you're going to have the opiate receptors partly blocked, you can give the regular opiates and they will work, but you just got to give bigger doses. Now the patient's right under your nose, they're on oximetry, you control the airway second to second, they're not going to get in trouble. That's just not going to happen. You know, overdoses occur when people are unattended or the only people around are fellow junkies that don't know what to do, this kind of thing. You know, in a setting where there are patients in an ambulance and on the way to the ER, that's not a risky thing to do. Now, part of our program, this isn't Cox's program, but I staff at Jordan Valley, and we have a program where we treat addicted pregnant moms, and we've got an excellent track record with it. Well, of course, the patient goes into labor on buprenorphine, and the anesthesiologists all have to pick up the football with a partly blocked patient. And there really are minimal problems in that situation. You know, women have their babies and they're reasonably comfortable during labor, and then they're on bupe right up to the time they start, and then we continue it postpartum. I mean, we don't stop the drug. For the record, a woman can breastfeed on bupe, that sort of thing, but that's a super common situation where you know you're going to need to give pain relief. Buprenorphine alone is not going to be enough for the pangs of childbirth. Well, the anesthesiologists treat that very routinely, really, with no particular problem. Very good question.
How about the ones that are clean, you know, take
It's a good question. Some will refuse. You know, they'll just say, I don't want an opiate of any kind for any reason at any time, which is, you know, that person's recovery. They got to decide that. If the patient's in enough pain, I think that unlikely, though. You know, they'll take the medication if you request it. Again, I've got people that are clean, that are on bupe, and they have elective surgery, something of that kind, and the surgeon says, well, I want you on some post-op. And I say, look, I'm fine with that as long as the surgeon knows you're an addict, and they know that you can't be on it very long, and you stop the bupe while you take it and then go back on it after you're on it. I don't prefer it, but sometimes the surgeons just really don't listen to it.
Well, sometimes they'll ask us, is that going to cause me to have anxiety?
Well, you know.
So I don't know the answer.
Okay, well, a very thoughtful and completely valid answer is you're getting this medication on order of a doctor in a medical setting for a reason that we would always need to treat pain. And we deal with the, you know, concerns about returning to addiction after we take care of your acute problem. I think that's always worthwhile and patient advocating. I do. And I mean, I've had this happen my share of times in the real world. For the patient that's really in good recovery, you know, it's a bit of a temptation, but most don't get back into addiction and abandon their recovery efforts because of it. Well, you know, I mean, some fears are needless and some fears are very needful. That's a needful fear. That's legitimate, but it's something that can be managed if the medical attendants have good insight into it and the patient wants to stay clean. You know, what's much more common is, hey, I'm a clean addict, sprained my ankle, can I please have about 10,000 per post? You know, I mean, they're not clean at all, and that's an Oscar award-winning act, but, you know, that's not a recovering patient. That's a favor. So, with respect. You hear this stuff about doctors that prescribe Suboxone Subutex for opiate addiction have to have waivers from the DEA. Absolutely true. It's not an urban legend. All of us at the center, for obvious reasons, do have that. But there are forms of buprenorphine that can be used for pain management that don't require a DEA waiver. I'd like to get into that in just a second, talking about the chronic pain piece. But the thing about, if the diagnosis is opiate addiction and you're giving an opiate derivative, that makes the government nervous. So we have to have special C&E, and then we have to actually get a waiver from the government, and all the stuff about changing your DEA number and so on, that's all true. That's correct. The waivers are printed on our prescription pads. You know, so those are kind of details, but I think they're worth touching on. That's true, and that's bread and butter for us at the center. Right. Methadone, that's worth touching on too. My boss at the center, Dr. Carlson, is also medical director of the methadone clinic, which, for the record, is a freestanding business. It's not owned or operated by either of the hospitals, or for that matter, by any other large general medical provider. Behavioral Health Group is the name of the company. Methadone in general is given per day right at the place that is the clinic, and it's not prescribed. And the person has to show up every day, get their methadone, and then show up the next day. They'll do stuff like give one extra from Saturday to Sunday, that kind of thing. Costs about $100 a week, and they're not interested in your problems. You know, you pay the money or you just don't get treated there. But that does include things like drug screens, the counseling services that they do, this sort of stuff. Methadone's been around a long time. For the record, in the science, it is a full agonist. It does cause tolerance. It's at least as long acting as buprenorphine. So you take methadone enough to get a steady state concentration. It's many days before you're methadone free. And that's for both good and bad. You don't go into sudden withdrawal from it, but it's also very long acting if you're overdosed. You hear horror stories about people going to parties, taking somebody else's methadone that they stole or diverted, squatting down in the corner and losing their legs because they took 100 mgs of methadone and couldn't feel a thing for however long it took their leg circulation to die. Now, this kind of stuff, those are real events that happen. And if you Narcanize a methadone overdose, the methadone's in their system much longer, so that when the Narcan does eventually wear off and leave the receptors, the person will go down again. So that's an especial caution. But is methadone legit? Established treatment for her or for opiate addiction? Yeah. And there's a facility in the city here. All big cities have methadone clinics all over everywhere. I guess some are government funded. I don't really honestly know that. They're not here though. And I really want to get into some details about the patient's experience at the center and will soon. But know that we have a full range of services for the addicted patient. All three of us docs are waivered. We all use buprenorphine. The patient is in a very intense, rather lengthy experience where they're in what amounts to a full-time job for a month, 8 hours a day for 4 weeks. The center takes Medicare and it takes private insurance. I don't want to get mercenary here, but we do have to turn people away if they do not have coverage for it. I'm on staff at Jordan Valley, and Jordan Valley has a substance abuse program staffed by none other than WA. And we do take Medicaid and we do take self-pay patients. I've actually got quite a number of people that aren't eligible to go to the center because they don't have coverage for it. So, and as I say, all buprenorphine preparations are expensive. There are none that are cheap. So some people don't have the insurance coverage to buy the medication. Suboxone costs about $1 a milligram. So if you're on 2 strips a day, which is common, $16 a day, well, 30 times that is what? $480. It's almost $500 a month drug bill if you're paying it at retail. It's not a small thing. Now, if you're on $500 a day worth of heroin, that's highly cost effective. But people will often not think that thought. They'll come in for treatment and expect their treatment effectively to be free when they've been committing crimes and doing all this stuff in order to buy their horse, and it's kind of, I guess that's the addictive brain at work. So can we get on to chronic pain management now? Is that of interest? Okay. I do both. There is no chronic pain center at North. Dr. Buxbaum, I think, is the chronic pain doc at Farrell Duncan. I've met the man a grand total of once. I honestly don't know a lot about what he does there, but we have a chronic pain management service at Jordan Valley. Whether we like this fact or whether we don't, chronic pain treatment and addiction have an unseemly and inevitable overlap. Some people who really don't need medication for pain or don't need opiates have a real good story, and somebody up or down the line puts them on opiates, and then they either are already abusing or they become addicted because of their experience with treatment of pain. So we're on a constant tightrope walk. The United States government, in its wisdom, has published what amounts to directives, they're really not suggestions, about maximum doses of opiates to be used really for any patient. There isn't any flexibility here. For the record, it's 120 mg per day of morphine or its equivalent. Now, that's a lot of morphine. This is oral medications. None of these are long-term injectables. Morphine pumps, that kind of thing, I'm not talking about. Oxycodone, hydrocodone, Dilaudid, even methadone, even the fentanyl patch, all have morphine equivalents, so they've all got dosage maximum. And also, opiates in a combination with the benzo tranquilizers, as you know too well, is a deadly combo. So by policy, which we are really not flexible about at all, if a person's on benzos, they can't be on long-term opiates. Many times we get into kind of a get-down with the psychiatrists of the world about this matter. But I say, look, doc, you can treat your patient's chronic pain. Nothing's stopping you. But if I am treating it, you're not going to give them a handful of Xannies every day. That's just not really going to happen. So these are unpleasant realities. We do drug screening very aggressively. I don't know how many patients I've had to let go from the service because of illegal drugs present in the urine or unordered other opiates. Because for obvious reasons, we have a no-to prescriber rule, and in violation of it is one offense, you're gone. I just wrote a letter dismissing a patient I'd taken care of for a year who was positive for meth. Too bad you can't get class 2s from me anymore. That doesn't go away. So those are the realities. There aren't an awful lot of doctors willing to take this football for that reason, because the abuse potential is so high. For obvious reasons, if a person alleges their medication was lost or stolen, we have to disbelieve them and can't replace it, because that's such a famous way to get abused. If a person refuses a drug screen, it counts as positive, because we have to do that. I don't know if you're aware of this little technical wrinkle, but we can do drug screens on saliva. So a person who conveniently can't urinate that day or ever, we just get saliva specimens. You want to guess how many negative salivas we usually ever get? Because the person's dirty, they just won't give us urine, so we use saliva. Lab takes it and runs it. No trick at all. So that dodge doesn't work. Again, I'm not trying to be flippant. I'm there for the patients who are there for medical care. People that are there to game the system, get a hold of medications they can divert and sell, not so much. And those are the realities of treating chronic pain. Can we use buprenorphine for pain? Yes. Is it effective and safe? Yes. Can we treat a person who is an addict and also has a painful condition? Yes. It's a little tricky. Our choices are limited. The patient has to understand that. But I've got a double handful of people that have admitted opiate addiction and are also legitimate chronic pain patients that I give buprenorphine preparations for. And I would like to re-emphasize the point, for pain, any physician with an open DEA, no restrictions on a DEA, can order preparations of buprenorphine for pain. It is not just for addiction, and you don't need a waiver if you do that. Pretty well known as the Butrans patch. I'd be surprised if everybody here hadn't seen a patient with a Butrans patch on. It's not the fentanyl patch. It's good for a whole week, which is kind of cool technology. The doses are relatively low. Like the biggest patch they make is 20 micrograms, not milligrams, but micrograms per hour. But for the patient that tolerates it and it works well, it's a great treatment. And you don't need a waiver in order to prescribe that. There's a less well-known preparation called Belbuca that's put in the cheek pouch, and it's available to anyone with DEA. You don't have to have a waiver to use that. I'd be a little surprised if everybody here has seen Belbuca, but you probably all seen Butrans. Do we try not to use opiates? Yes. Opiates are not the treatment of choice for any chronic pain if we can get away without them, but I don't get the easy patients. Anti-inflammatories, muscle relaxants, antidepressants, GABA-type drugs, sure, but usually the clinicians have tried all those before they refer the patient. Are we extremely careful not to treat a surgical problem as a medical problem? Extremely. So we have very strict regs about proper imaging. We prefer surgical consultation where the surgeon said, not going to operate or not going to operate again. Of course, it's common, or the patient's not a surgical candidate, morbid obesity, severe diabetes, whatever. But those are all things that we do almost as prerequisites before we put a person on service, even. Do we have a lot of folks? About 500. Jordan Valley attends about 15,000 people. So, it's relatively few. But it's enough that the clinicians are absolutely ecstatic. They don't have to deal with the pain. They can deal with the high blood pressure, diabetes, and so forth. Well, sociologically of some significance, I think. So I've jumped all around it and stayed in my syllabus. Now the back side is the handout that I give to the interns at the center who are not clinically trained. They're psychology people. And it's really just meant to be a kind of a nuts and bolts introduction to the terms. What is this Suboxone stuff? Do we have similar medicines we can give for alcohol or other drugs? That kind of thing. So this is kind of a bare bones entry level. But I think it's worthwhile to see the contrast, because this is for fellow doctors and fellow practicing clinicians. Quite advanced, and this is relatively meant to be simple. But I think the simple approach always helps when we're teaching, and not just our patients, but interested community members and the patients themselves. Anybody tell me the chemical name of heroin? I'll be impressed if anybody knows that. Doc, It's diacetylmorphine. Heroin is just morphine with some clothes on. And heroin is actually a prodrug. The reason that it's so addicting is because it penetrates into the brain so quickly. But the acetyls are taken off chemically, and what hits the opiate receptor is still morphine. It was named because it was heroic. It did all these things that regular opiates couldn't do. It was synthesized. It's not a natural substance. Well over 100 years ago. And it was used to treat morphine addiction initially because the people, this is much better. Oh, yeah. And heroin is still available. 100 doctors in the country, I think, have special permission to use it for horrendous cancer pain, this sort of thing. It's still available, but not by ordinary prescribers. And for the record, the fentanyl patch, I don't start people on fentanyl. I've inherited a few that were stable on low doses. Fentanyl's a great drug for cancer. It shouldn't be used for patients with a life expectancy. And that's a clinical opinion. It's just too dangerous and it's too addicting. I don't know if you've bumped into the behavior about chewing fentanyl patches or cutting them into strips and rubbing them across the conch to absorb it. But I actually had an OD. I had to Narcan ice on the floor of a bathroom at Jordan Valley because he chewed his fentanyl patch. My patient, my prescription. Abusive. Well, you tell me. You didn't get no mo. I'd like to run through the slides if I haven't worn you completely out, because the experience of a patient going to the center, I think this shows pretty well. I put it together for that reason. Any other questions about this material? Well, the main thing about the center itself should be self-explanatory in the brochures. We evaluate anyone who asks to be evaluated. The person may be told you're not a candidate to come into treatment for any of several reasons, but the doors are wide open for a person to be evaluated. And so it's a very user-friendly experience. You don't need referral from a primary care doctor. People can self-refer, this sort of thing. So if in doubt, send the patient there. Let us see what we can do. As I say, we're up north where not very many people work. And it's not real subtle because it says Center for Addictions in great big black letters across the door. So we get it that it's hard for a person to walk through that door. That's not easy. You're not coming in for high blood pressure and diabetes. You're coming in for addiction. That is not easy for a person to look in the mirror and say, I'm an addict and I better go see a doctor for it. But we're there for the patients. Why don't everybody at least get up and take a little stretch? I do. Yep. If I can remember how to operate it. Delighted to talk to interested people one-on-one afterwards too. That would be a privilege. All right, so here's 30 slides. That's normally an hour's worth, and I'll try to be merciful about it. But if I hit something interesting, please feel free to ask for elaboration. So this is me, and that's the center. Here's our staff. The medical staff is Dr. Mark Carlson, who's my boss there, Dr. Bob Elworth, and myself. None of us are psychiatrists. We're all primary care doctors. And for the record, we're all there part-time as far as when we see patients. Dr. Carlson works full-time, but he's only in clinic 3 days a week. I'm there 1 day a week. Dr. Bob is there too. It's just the way the staffing is. And we have an RN, we have a PsyD who's full-time, and then we have our various people that are trained counselors. This gets to be pretty big alphabet soup stuff. I don't even know what all the acronyms even mean. My colleagues there just smile when I say that. We're under the radar because nobody goes to most. We kind of like it that way. And that's the way the door looks. Anybody that's never driven by, there's nothing very subtle about it. Person comes to a reception desk like any other medical office. This is the way the counselor's office looks. That's a classroom. For the record, I give lectures to our patients on a number of topics, all of whom are open source, which are open source if the person wants to see what material I cover in those. My favorite I call psychologies. Psychologies is a foreign language spoken by mental health professionals to confuse and annoy our patients. I try to say, what's schizophrenia, what's bipolar, what's, like that. And I've had many people say, gee, that was really very helpful. That's Dr. Bob. He's the photogenic one. And yes, we have examining rooms. Now, we're quite diligent in our process. A person's not even seen by a staff physician unless they're intake by the counselor and said to be suitable for treatment. And there are really quite a few people who come that we can't admit for whatever reason. We do a complete history and physical exam. We have to be very careful about coexisting medical conditions, although for the record, for the opiate addict that needs buprenorphine, we rarely can't give it because of other medical problems. And then this induction thing of buprenorphine has never been used before by the patient. We supervise the first dose, mostly for tolerance. It always works. We got a person that's hurt and withdrawal, and we give a dose of Suboxone, and in 30 minutes they're comfortable. And we show them right there on the scene that it will work. And again, most people are fine. Get a little itching, get a little nausea, some of that sort of thing, like you can with any opiate. It's rare side effects will limit treatment. This is really for the psychologists, person to person, sit down, make eye contact. But we try to make this a very user-friendly experience. Speak English. Psychology is usually not a first language. We've had a few clinicians in treatment. That gets interesting. It does. It really does. This is a little too specific for the general population, but it restates when a person asks how far gone their liver is. I'll say, well, I'll give you a percentage if you want one. You got to hit 90 before you die. But the answer to your question is get sober. You've got enough liver left to make it on if you quit poisoning your liver. This wound, the self-esteem thing, even returning after a person's walked through the door the first time. Many don't. They come in one day, we never see them again. It's a difficult thing. Just anybody here that isn't recovering, think of how you'd feel yourself if you hadn't realized that about yourself. Does the center use the traditional 12-step program and that sort of thing? Yes. Is there a program for people that are unbelievers, that don't really want to have a higher power and don't want to pray the serenity? Yeah, there is. It's called rational recovery, and the counselors are all trained to be sensitive to the fact that some people are non-religious or a-religious, anti-religious. Do we have suicide ideation? Pretty commonly. Every so often the nurse will take a person down to ER for presumed admission to psych for that reason. That's pretty self-explanatory. Now this is kind of interesting that I wanted to elaborate a little bit about drug testing. When we take a specimen, it's done very, very carefully with we don't delegate this. A member of the staff takes the patient down, gets the specimen. In cases where we have doubts, it's an observed specimen. We actually observe the specimen being voided. It's sealed and initialed right in front of the patient, and then it's picked up by a designated courier at the lab. It's not mailed. It's not sent by somebody that happened to walk by on the street. The labs that we use are not in Missouri, so they've got to go a distance. There are relatively few around the country that are sufficiently well certified. So when the lab gets the specimen, the first thing they do is make sure it's human urine. They do creatinine levels. They do specific gravities. I don't know how many people have ever read High Times, but you can buy Urine Luck. Get it? Urine Luck. Okay, yeah. Usually it's Clorox, peroxide. And those will destroy certain drugs chemically, but they remain detectable. So the lab will simply report it out as it's got an adulterant and it's not runnable. Well, just, there are a lot of dodges. Temperature. The urine's temperature is checked. If it's below or above body temperature, then it's no good. We had a person not too long ago try to beat it. This was back in winter. He brought one of these iron filing hand warmer deals, to wrap his urine in. The urine was 103 degrees. That didn't really work. Plus, we ran it anyway, and it was positive for several illegal drugs. Well, it turned out it didn't destroy it adequately, but we knew it would be positive. He admitted it. I talked about the ethyl glucuronide, the medical review officer, cutoffs, the double, and it's actually triple checking of the results. The rapid drug screens done in ERs, including ours here at Cox, are one step. And some are falsely positive. An example which doesn't involve an illegal drug, but Flexeril is a tricyclic chemical structure, and it'll turn tricyclic screens positive. But that's a false positive for your L-albyl-tofranil. So just know those are only so reliable. The big advantage of them is they're fast. For most illegal drugs, they're going to be adequate and accurate, but for the record, they're not confirmed. So I don't make a diagnosis, even if the drug was present in the patient's system unless it's a confirmed specimen. And that is not routine in the ER drug screens. Talked about how quickly you excrete it. Marijuana is the gotcha exception. Buprenorphine can be detected. Buprenorphine is not looked for in regular opiate drug screen specimens, but it certainly is detectable. So that proves the patient's taken their bupe. Because it's of great importance that the patient's compliant. And they need to be negative for other substances, including any opiates and illegal drugs. Slowly excreted, as I mentioned. This pre-employment thing. And again, in an ambulance with a person on your gurney critically, you're not going to be discussing things like this, but I just think it's worthwhile background. A person on buprenorphine won't have it detected during a regular, normal pre-employment screen because it's just not looked for. This is an example of how the drug screens look. There are many, many, many channels. This particular person had amphetamine detected even though they were still positive for their buprenorphine. I don't know if that's visible from back there. But, it's a real intense report. There's a huge amount of information on it. The cutoffs are shown, the screening method, and then the confirming is shown. I mean, it's very thoroughgoing. This is kind of another similar one. But all the stuff about checking to make sure it's really human urine and this sort of thing, that's done routinely. So we got one not too long ago that was tap water. And we see Mountain Dew, we see ginger ale, this kind of stuff. Well, the person's just trying to get lucky. And these are the topics of the talks that I give. The psychology, as I mentioned. What would you think if we had a Center for Addictions and we didn't bash smoking? Right, we got to do that. For the record, smoking, because it's a co-addiction, you continue to smoke while fighting any other addiction, you cut your likelihood of a recovery in half. You successfully quit smoking, you double your chances that you'll successfully recover. That's how big a deal it is. Everybody who smokes should quit. Hello, no extra charge, but that's a specific reason for the person in addiction treatment. And many people kind of hear the word. They've been around the track quite a few times. They've had some ODs. They've had some friends die. And I say, if you're pulling out all the stops, using every arrow in the quiver for your recovery, you really need to quit smoking this time. No good intentions. Do we require no smoking? No. Are there addiction treatment places that do require it? Mm-hmm. And they'll test for nicotine in the urine. They won't just take the patient's word or see if they don't smell like it. True. Harms of drugs and abuse we've gone over, I think, enough. But these are all talks. The handouts are available to interested persons. And then I try to touch a little on this, the CDC directives. They were published in April of last year in the JAMA, if anybody wants to look them up. Big no-no about combining the opiates with benzos. Can a patient be on bupe and be on benzos? I don't like it, but I'll permit it as long as the patient's otherwise stable and the psychiatrist knows something about buprenorphine, which most at least knows something about. For the record, all antidepressants are okay for a person in recovery. All antipsychotics and all bipolars are. The anti-anxiety medicines, for obvious reasons, that's not true because of the benzo group. But Buspar is okay. Many antidepressants are double indicated for anxiety and depression. All muscle relaxants except for Soma are okay. We use the term nerve stabilizers for Neuron and Lyrica because it's just easier for people to understand, I think. Isn't Lyrica like prison Valium though? Can't you buy it? It's a controlled substance.
Yeah.
It's class 4.
Smash it down.
I think you can buy it in prison. We can give buprenorphine to pain patients. So, questions about this? Yeah, I've got 2 more, so. Now, I don't want to wear you out. I just think it's good enrichment material. Can somebody that knows the tech make sure I can get the other PowerPoints open? I'm not sure how to do that. Russ? Okay, thank you. But the center's real, our people are real, our patients benefit from what we do. We've got a good success rate. Some of the people that need to be in treatment don't have coverage. The people that are self-pay, the center requires that they pay a pretty substantial fee, but it's much less than the full retail price. So we do everything possible to get people in treatment together. Again, this may sound mercenary, but the center, like any other clinical service, can pay its way. And there are resources available for the people that are uninsured or on Medicaid, as I mentioned also.
So why don't you have full-time staff positions at?
Because we're all so old.
Addition.
I'm on Medicare.
Well-
I'm on Medicare not because I'm on disability, but because I live long enough. And, Dr. Carlson will be 69 next month. Dr. Bob is 66. You know, we're just all old men. No, kidding aside, Mark is full-time as medical director, but Bob and myself are semi-retired. You know, we're both
Right.
long years FPs, but we're not full-time.
Are we not recruiting?
Yep. But here's the problem. Board-certified addictionologists are not very common. There are about 6,000 doctors practicing to one degree or another in addiction medicine in the whole country.
But that's where the life is going, appears to be.
Yeah, but it's,
Money must be in it.
they're recruiting for an aborted addiction medicine doc to be medical director. Now, there is an addiction service over at St. John's. I don't know a lot of details. Dr. Kewick is involved, Dr. Sharma is involved, Dr. Sal Sinoceros is a waiver provider. Those are all psychiatrists. Now, I honestly don't know those colleagues as well as I should, but it isn't like Mercy has nothing. We're ready with the next one?
Harms,
Yep.
that's the one.
Now, this I really do promise I'll go fast on, but I need to start the slideshow.
There you go.
Thank you. Nerdish spoken here. So what's an alcohol? I promise not to drown you with that answer. If it has an OH, it's an alcohol chemically. Here's all the stuff about how much your blood level goes up and what liver metabolism is. Some of the stereotype about alcoholism is drunk driver driving a Suburban, pull up people, gets another Suburban hit on. Everybody else is killed instantly and the drunk doesn't get a scratch. Of course, statistically, that's not true at all. A great treatment for alcoholism is death and trauma. So, that's enough said. And I would mention, a person can die of alcohol withdrawal, PDs. Even with an experienced attending doctor like Dr. Carlson, there's still a mortality rate. All the pancreatitis, I'm sure you've seen quite a lot. It's kind of amusing. Many people mispronounce the word pancreatitis. Well, you know, they're really closer to the name of the organ than we clinicians are when you think about it. So, you know, if you hear that word, the person's at least heard of it. You can get a cardiomyopathy from alcohol, and everybody knows about the macrocytic anemia. Well, if your bone marrow cells are drunk all the time, they're not going to produce real whippy white red cells. This is a little thing about psychiatrists asking to reevaluate a patient that's an alcoholic just because when you quit poisoning your neurons, your mental illnesses may be quite a lot better. Cancer risk is often not appreciated. My best friend, a fellow doctor, died of a cancer that originated in his tongue, 3 packs a day, and when he was not on duty, he was always good for half a gallon of vodka a day. You know, he got a primary in his tongue and killed him. So this isn't something that's, you know, theoretical to me and my best friend. Interacts with other sedating drugs. A person who takes alcohol and something like some Benadryl, well, they're warned in the, or even a prescription antihistamine that's sedating, they're warned in the prescribing info that it interacts with alcohol. And if the person isn't legally drunk, but they've got another sedating med, they're legally responsible for being under the influence because of that. It's a true story. Yeah. Okay. This is adrenaline. This is dopamine. And this is meth. As you can see, they're very similar except for the OH is not being present over here. The meth in question is here on the amphetamine molecule. Oh yeah, in Southwest Mo, cooking meth is a cottage industry, and our meth, when it goes out to Californicate, is much valued and known as 417. That's a true story. You can ask the people out in California that are meth heads. Oh, they love 417.
New York too.
Okay, there you go. I-44 is the meth highway, meth interstate.
Buddy of mine, same thought of New York.
I had an experienced drug addict say this about meth. Never met a drug he didn't like. But he said, I don't know why these people do that meth. You get a 20-minute high that's pretty decent, and then you're buzzed up all day for 24 hours, you know. Well, he was a drug-loving druggie, but he didn't like meth. You get meth teeth. I don't know if this is in scientific literature, but the vasoconstriction of the little arteries in the pulp of the teeth is what it seems to me would be the mechanism of why your teeth decay. Maybe somebody knows that for sure, maybe they don't. Coke, kind of an interesting molecule. This is really cool. Cocaine is a reuptake inhibitor. The biochemical mechanism of action is it inhibits the reuptake of the neurotransmitter, presumably serotonin or dopamine. Perfect heart attack drug, 2,500% greater than baseline risk of having an MI within so many hours of taking coke. Makes platelets sticky, changes circulatory dynamics. And there's a combo of cocaine with ethylene. I had a nurse in treatment, or ethanol. I had a nurse in treatment not too long ago who said, well, to him, the perfect party was snorting coke and drinking shots. And he said, yeah, the combo is better than either one. Oh, he was quite an addict. Now, this is kind of cool. Morphine, which is harvested from opium poppies. It's grown. It's a crop. It's named for the Greek god of sleep, Morpheus. You're in the arms of Morpheus, means you're asleep. This is the prototype opiate. Starts life as an opium poppy. Note these OHs. So is morphine and alcohol? It is like that. Just a very sophisticated one. Here's morphine. Here's codeine. Very little difference. Just one methyl group. Heroin, diacetyl morphine. And here's naloxone, which is the name, which, as you would imagine, is very closely related to morphine because it interacts with the mu receptor on the nerve cells. And this is bupe. It's very, very chemically tweaked so that it's hard to metabolize, and it's both an agonist and an antagonist. All opiates cause all this stuff. Everybody knows that. Itching, one small thing is when a person gets itching from opiates, they don't get a skin eruption. So, you know, it's an effect to me, not a side effect. What, half of all people, I'd say at least, that take opiates get itching? Does bupe cause it for some people? Yeah. Acute overdose, kills by respiratory depression. And as I say, many, many people, oh, it causes you to have a stroke or heart attack or cancer. You know, I mean, they really don't know. Opiates are relatively very safe if they are not overdosed. People are on them for decades for chronic pain with no particular problems with their internal organ function. But anybody can die. So here's dope. Is marijuana and alcohol? Dopers don't. I'm pretty politically incorrect because I don't think it should be legal, and there's no question that it's an entry or re-entry drug for almost everybody that gets on harder drugs. The pushers always got something bigger and badder when you're ready. Always do. And then this is my hate list here that is this. Xanax is said to be the most prescribed drug in the world. For the record, the FDA, in their wisdom, approves the use of benzos. This is all benzos now. They don't differentiate among the various meds for 2 weeks. You can read the prescribing literature. How do I know that? Because I had a PharmD research it for me. She didn't know the answer, so she looked it up for both of us. So they're approved for 2 weeks. We'd be lucky if people were only on them 20 years. But that's actually off-label prescribing. And it's not good medical care because you're living your life in a haze of brain chemicals. You don't feel better, you just feel less. Like taking a shot of booze. Some of those health risks for being an addict of any kind is risky sexual behavior, poor judgment, lowered inhibitions. And then I don't want to go too far into the anti-smoking thing. That's a little much. One of the things that people that are sincere may sometimes say is, well, why can't I use e-cigs or vapes or nicotine patches? Well, that's just all a source of nicotine. Well, the safest thing in a cigarette is the nicotine. Tar destroys your lungs and causes cancer. Carbon monoxide, cyanide, formaldehyde are the direct poisons. Hydrocarbons are also cancer causing. So the nicotine is the safest thing in a cigarette. There's another one, but I think I'll wear you out with it. Any other questions now?
I actually did have one.
Go for
On
it.
the, can't pronounce it correctly now, but the, sorry.
Go ahead.
The buprenorphine.
Buprenorphine. It's kind of a mouthful.
How is using that like on a traumatic patient? I guess somebody has a GSW and they're high on heroin, which most people I work with are. Is there any big contraindications with that?
Well, because bup is an antagonist, if you give bup on top of a person that's got a system full of another opiate, you put the patient into a partial opiate withdrawal. That way. But because it's an agonist, it's never going to be full-blown withdrawal.
Okay.
So all this fear about, well, no, I mean, well, you've given people Narcan. They go into complete total opiate withdrawal and hate you for it.
Yeah.
You know, you son of a bitch. You know, La La Land was just fine with me. Well, you would have been dead in another 10 minutes, but you know, the people, of course, the addict doesn't recognize that. But bup was always going to partly treat withdrawal as well as blocking other opiates.
Okay.
So once again, it's a way it's so safe.
Okay.
Very good question. Anybody else? I've achieved perfection. Somehow I doubt that. Just if you know of a person that needs to go to the center, it's a very user-friendly experience. Doors are open. The brochures are self-explanatory. I hope I even have some appointment cards someplace that are a little handier to carry. And I'd be glad to talk with interested persons about details if you wish to come forward at the end. But I was done unless there was another question or issue. Okay, thank you very much for your attention.
Thank you.
Hopefully, you'll save some lives just because you know we're there and we can treat folks. And prevent some, you know, some runs, hopefully.
That would be nice.
Hey, Dr. Pirotte, boy, I got some things for you. So I would start to envision a trial. You know, the clinical question would be, would simultaneous administration of Bupinex and Narcan to the suspected habitual heroin overdose reduce our overall use of Narcan over a certain time period?
Probably somebody has done a study like that.
I can't find it, it's not on PubMed.
All right. Well,
But that's
what
the
they
trial.
always bill naloxone as a rapid detox. One of the things that was done back in the past is they put a person to sleep, give them general anesthesia, and then just blast them with Narcan and for like a couple hours under general anesthesia. So the person was completely through their acute withdrawal, still asleep, but they were completely clean of any opiates because of the Narcan's effect. You know, it's called rapid opiate detoxification. I don't see it revolutionizing addiction practice. But as I say, buprenorphine is so benign, it's so safe. If a person's had a previous experience with it, they may be very willing to take some of you if you've got a willing provider there, you know, this kind of thing. But it's going to prevent acute bad withdrawal because it just does that. It has that effect on the mu receptor in the neuron. And then it's going to block trials of using other opiates. And that'll be probably a full day and a half, something like one of those. So.
Just study.
We'll just contact Mark. I'm sure Mark is actually trained and certified in preventive medicine, and he's all over public health and you know studies like that, all over. You know, he'd be a very big resource that way.
Already paid me.
Okay. Well, I just called him before I came there.
Yeah.
He was trying to make it, but it was just too busy. Mark Carlson, Dr. Mark Carlson, almost everybody at least knows of Mark, I think. He's pretty well doctor of addictionology in Springfield. Been around a long, long time.
Patients ask for
Well, as you might imagine, an awful lot of the folks we get on inpatient service never even call the center, let alone come into treatment. You know, you'd think that a fair number that were sick enough to be inpatients would realize maybe they have a problem, but the denial is still very much there. One fun story, anybody's free to go anytime, but this is really a fun Mark Carlson story. Okay, so we got Joe the drunk, who's been in 4 times in the last year with BACs of 400. Hasn't managed to die of DTs, although he's made some nice tries. And he's 3 days later and feeling great and ready to go by the liquor store on the way home. But of course, he's not going to tell Dr. Carlson anything of the kind. So Mark will say, well, you feeling ready to go? Yeah, oh yeah. You know, drinking? Oh, no, sir, no, won't touch a drop. So Mark will say, well, I'll tell you what, why don't I have the nurse give you a dose of antabuse before you go home? I'll prescribe it, but I'd like her to give some before you go home. Oh, no, I'm going to be sober now. I don't need that stuff. And, well, you wanted a prescription for it. Well, yeah. Well, why don't you take the first dose right now? And then you can't drink for 5 days or whatever antabuse will do. No.
Not obvious at all.
I mean, that's just a little fast take. But he will do things like that. Another really cool thing Mark Carlson does, a person that's been in treatment before, maybe several times, they'll say, okay, what's the first word of the first step? People have taught in treatment centers this concept. Well, I wouldn't expect anyone here who isn't recovering to know, but it's weak. It's not I, it's weak. We recognize that we were powerless against alcohol. Everybody flunks that. They don't know that. So much for having really gotten the 12 steps to heart. I mean, he'll do things like that just to get the attention of the person who's really not there. Yeah, they haven't recognized the problem, and they know what to say in order to kind of deflect the incomings, that kind of thing. Carlson also is fond of pointing out tobacco kills 5 times more Americans than alcohol, legal drugs, and illegal drugs put together. So I just touched on smoking, but he's very, very emphatic about it. And we do, rather intensely preach against smoking in the center. But the thing that's so funky is, of course, Cox is a smoke-free campus every place. So the people go across the street to suck on their butts between lectures. Yeah, I know. These are not model citizens in many instances, but they're human beings that were there for us if they want to work the program. Other additions or subtractions? Pleasure. Best of luck out on the streets.
Thank you so much.
Thanks for asking me.
Let's watch.
Never been.
Wait.